Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation CME meetings. And today we have Nephrology Clinical Forum, which is handled by Egyptian Institutes of Nephrology. And today is the day of Suez Canal University team to present their cases and enjoy us with the case presentations and discussion. First of all, I would like to welcome our moderators, Professor Dawla Bilal, Emeritus Professor of Nephrology and Internal Medicine, Cairo University. She is the head of scientific committee of Egyptian Board of Nephrology, and she is the past president of Nasr al-Aini Center for Nephrology and Transplantation. And our second moderator is Professor Hamdi Omar, Professor Hamdi Hassan Omar, who is the Professor of Internal Medicine and Nephrology, Suez Canal University. Professor Hamdi is one of the board of Egyptian Society of Internal Medicine, Egyptian Society of Nephrology, and he is currently the head of Nephrology Department of Suez Canal University and the director of Suez Canal Nephrology Hospital. Professor Hamdi received his PhD and his nephrology training in Karolinska Institutes in Sweden, and has got his specialty degree from the Swedish Board of Health and Welfare. First in internal medicine 2015 and a specialty in nephrology 2016. He has many publications in the field of nephrology, diabetes, and infectious complications after organ transplantation. I would like to welcome our moderators and give them the floor. First, Professor Dawla to introduce the session, and then to Professor Hamdi to present his team in Suez Canal University one by one and to present their cases. So please, Professor Dawla, take the floor. Professor Dawla.
كده سامعني؟
Yes, yes.
Okay. مساء الخير. Good evening, everybody. It's a great pleasure to be a moderator for this session. The three cases I have looked at, the titles are apparently very interesting, and I'm looking forward to listen to them. So you can please proceed. يعني.
Okay, Professor Hamdi, please take the floor and introduce your team one by one. To start by the first case.
Thank you very much, Professor Yasser Abdelhamid, for introducing me. And I'd like to thank you also for inviting me and our unit in the nephrology unit in Suez Canal University for this participation, for introducing the cases, interesting cases that we think that they are good cases for discussions. And I'd like to welcome also Dr. Dawla Bilal for being a moderator with me today. First of all, I would like to introduce Dr. Mohammed Al-Koshawi, Associate Professor of Internal Medicine and Nephrology, and he's the director of the Suez Canal University Specialized Hospital. And Dr. Al-Koshawi, one of the active people in our unit, and I expect him to be one of the leaders in the future at the level of the university and the clinical level also. Professor Al-Koshawi will introduce an interesting case, and I'd like for him to start his case now.
Thank you, Professor Hamdi, for this generous presentation for me, my dear professors and my dear colleagues. I will talk today about one of the cases of the Merah-Bone disease that we had faced in our university. Okay. Okay. Regarding this young adult male, he is 15 years old, male patient, in the stage renal disease. since 2017 in South Canal Specialist Hospital. His primary kidney disease was chronic pyelonephritis secondary to neurogenic bladder, and his comorbid condition is hypertension. His complaining of left clavicular hard mass rapidly developing over a 2 weeks duration, followed by paresthesia of acute onset within 5 days at December 2017, 6 months from starting hemodialysis. Patient was vitally stable, and examination disclosed paralysis of his lower limbs, diminished sensation up to the inguinal region, and hyperreflexia for the knee and ankle. And the patient was admitted for further investigation. Regarding the metabolic profile of this patient in his pre-diabetic stage and 6 months dialysis, the average calcium level was 8.6, and phosphorus average 9.9 milligrams per deciliter, and his PTH was nearly stable at 400 milligrams per deciliter in this small period. And cardiovascular-wise, hemoglobin level is 9.8, and the echocardiography didn't disclose any diastolic dysfunctions or any wall motion abnormality suggesting coronary calcification or even calcifications involving the aortic or the mitral valves. Here we had done this CT for the clavicular mass lesion that appeared rapidly. And as you see, the comment of the radiologist was there is multiple osteolytic lesion involving the clavicle walls and both sides and right scapula even moving with crown tumor, and they suggest that secondary parathyroidism was the cause. And as you see, this mass lesion was about 7 centimeters in diameter. And when we had done this imaging immediately for the patient, because of his presentation with placid paralysis, we was astonishing to find there is a mass lesion at the level of T10 compressing the cord. So neurosurgeons, when they looked at this, and as you see, it apparently fleshy mass compressing the cord, they had diagnosed it as patient has a neurofibromas regarding this fleshy appearance in the CT. Other bone scan and other survey for the bones revealed that the patient has continuous proof, which is non-significant Haglund deformity in both slides, which occurs with pressure, and his pelvis didn't show anything involving the head of the femur or the neck of the femur, apart from mild retraction on the left side. When we go to the parathyroid, we have done this CT and we didn't find any apparent adenomas in the neck CT for these patients. And when we go to systemic scan, we again found there is no active uptake of that tracer, meaning that there was absolutely no evidence of parathyroid adenoma at this time. As the initial diagnosis, as I said, the neurosurgeon have done it is neurofibroma according to the appearance of the lesion involving and compressing the T10 roots. And they had done it by Professor Parakelina, who is the associate professor of neurosurgery. And as you see, complete excision was done for the mass. And as you note, the spine is straight. There is no any deformity involving the spine. And of course, the surgeon has noted that this fleshy mass was involving bony fragments while exceeding the edge. This is not a neurofibroma on this excision. And of course, the pathology report games consisting with a giant cell-rich lesion and the possibility of brown tumor with there. Okay. After 6 successive physiotherapy sessions, patient regained his motor power and he was able to walk again with no apparent deformity. And re-evaluation 2 weeks after the procedure for the bony skeleton, we was astonished that patient showed a scoliosis in his back involving the lumbar region as you see here. Okay. And the question again for the neurosurgeon, should the patient receive a corrective spine surgery? And what is the cause of this rapidly occurring kyphoscoliosis in these patients? And the decision for the neurosurgeon was to go for DEXA scan first. And as we see, DEXA scans, the score was -1.6 and the Z score -2.7. And this actually was keeping with the guidelines as we see by the previous guidelines. We can do memory testing to assess fracture risk as a result of the impact on treatment decision. But after this DEXA, neurosurgeons refrains from doing any corrective surgery, especially patient is osteoporotic, and patient has normal gait on walking. So he decided not to do any corrective surgery at this time. Again, we had followed our patient for another 18 months, a total duration of 18 months. And as we see, calcium trend all over this was 8.6, ionized calcium is 4.4, and viscous score was 4.1. I think this is ideal for a patient who has end-stage renal disease, 18 months is on hemodialysis. And again, his PTH level was in the accepted NIH range regarding our guideline to be 9 from 209 all rise from the upper limit for the PTH, and even it was decreasing with our treatment plan. Alkaline phosphatase also was decreasing from 500 and stabilized at 250 around 90, which is also accepted. So PTH and alkaline phosphatase showed a substantial and sustained down sloping on the 18-month duration. And if we look at all the duration before the occurrence of the patient presentation and after occurrence the patient presentation, as we see calcium, ionic calcium, and phosphorus seem they take a stable trends all over 1.5 years of his course. PTH level and the alkaline phosphatase is the same, taking the same down sloping, slowly sloping then but all the time from the starting of his hemodialysis till 1.5 years, patient has normal range of PTH or acceptable range of PTH regarding his biochemical profile. And it was astonishing that this mesh lesion that occurs 6 months of starting his dialysis started to recede spontaneously, just while sloping PTH and across this downward, this lesion was starting to decrease. And the question to be vested, do you agree that crown tumor was the initial diagnosis? And does crown tumor occurs in such levels of PTH secondary hyperparathyroidism, I mean the primary? Does the short course of hemodialysis with such metabolic profile leads to this presentation? Has bone biopsy a role, and has senile calcium any role in such levels? If we look rapidly, the brown tumors are giant cell rich focal lesions due to primary or secondary hyperparathyroidism. So it can occur secondary hyperparathyroidism, which may have extractive effect. It was reported that it's extensively with primary hyperparathyroidism, but with increased in end-stage renal disease longevity and hemodialysis cases due to secondary hyperparathyroidism was reported. The incidence was very rare, 1.5 to 1.7% of end-stage renal disease may develop brown tumors, and brown tumors can arise anywhere in the skeletal, but mostly encountered in clavicle, ribs, pelvis, or both limbs. But many clinical lesions also has been reported. Up to date, I have found 14 reported cases of brown tumor with chronic kidney disease, starting from 1978 till 2016 until this present case was presented. And as you see, mostly of them were females, predominating males. Okay, for cases occurs in chronic kidney disease and the other occurs in hemodialysis patients. And too much interest, the PTH level to which brown tumor has occurred. As we see, there is a great variability in this. We can find 300, we can find 1,000, or than 3,000, or than 2,000. So we have a big range of PTH levels that can withstand this 14 related cases. And regarding kidney biopsy, as we know that the recommended kidney biopsy is indicated in unexplained refractory hypercalcemia, suspicion of breast hemorrhage, or any atypical response to the standard cell to elevate PTH and progressive decrease of bone mineral density despite in the standard therapy, and it's also, of course, to rule out atypical or unexpected pathology, will determine whether it is high or low turnover disease, and identify any mineralization effect that can alter the treatment, especially alcohol toxicity. Okay. And the question was what target and how to tackle. The clear guidelines like in the Enhanced 3 and Cosmos study to get their data, and as we all know that we have in our armamentarium the following steps. We can control phosphate by phosphate type or phosphate binder, dialysate, calcium, optimizing oral calcium dosage, administration of vitamins preparation, or calcium mimetic of measles, and again, parathyroidism is offered for treatment of health refractory and hyperparathyroidism. But the PTH dilemma remains the same. In 2009, all 9 with all the new guidelines, the PTH level is 150 to 300 grams per millimeter based on expert advice. And in 2017, the recommended range was approximately 2 to 9 times of the upper limit of the C, and it's related to C. Okay, and this was relying on this mega trial, which involved more than 9,000 patients involving peritoneal dialysis or hemodialysis hemodialysis done by RE, and they recommended that PTH has a U-shaped relationship with cardiovascular mortality and recommended to be the level between 200 and 700, and this was enforced by the EVOLVE trial and the Forum-Suez trial. But the Asian revokes this range, and they said that all these trials didn't include Asian population in a sufficient number, and the Chinese, for instance, in 2019 done this mega trial, and they recommend the PTH from 100 to 350 grams per millimeter, like the older guidelines, to be the reference range. Even the Japanese, in their guidelines for the Japanese Society of Nephrology, recommending a range from 80 to 260 grams per liter for the Japanese population, taking us back to another lower limit. And there is still a heat on what target of PTH, and it's still clear in clinical practice that it is difficult to identify the point of transition of the physiological compensatory response to a maladaptive process, where biochemically accepted serum calcium and phosphorus level is made by the deleterious systemic effect of PTH. From Ismailia, with love. Thank you.
Thank you very much, Professor Muhammad, for a very interesting but confusing case. I have a question. Did he develop acute scoliosis after removal of the brown tumor?
Yes, that was the case. 2 weeks after the operation, when we surveyed the patient, as you see, he developed scoliosis, which was astonishing for us to find this after
very
the
acute.
operation.
This means that his bones are severe osteomalacia, and maybe the spine was supported by the tumor.
Yeah.
And when you remove the tumor, scoliosis happens, something like that. And what happened to the brown tumor in the clavicle? What happened? Did it disappear, or it's same, or what?
It decreased. It was decreasing over the 12 months, as you see by the and decreased to this side after 12 months of keeping or controlling his PTH level. And as I said, we had just decreased his PTH from 590 to only 300. This 200 picograms has resulted in regression of this brown tumor spontaneously.
Yes. So this is a case of secondary hyperpara.
Yeah.
Definitely due to the chronic renal failure. He had chronic renal failure due to pyelonephritis, or what exactly was it?
Yes, this primary kidney disease was chronic pyelonephritis secondary to neurogenic bladder.
Why neurogenic bladder?
This was during childhood. His childhood, and he is maintained on CIC, continuous intermittent catheterization by himself during all his childhood. We don't know exactly what is the nature 15 years dating back for that.
Yes. It's a very strange case, and the story is now controlled by controlling the level of the PTH.
Yeah.
And how did you control the level of the PTH? He had normal calcium, right?
As you see, my professor, that his PTH level all over his course was accepted.
Oh, it wasn't too
As you
high.
see, yes,
Yes.
it is 590 to down to 290.
And
So
the calcium never exceeded 9.
no, it wasn't noisy at all.
So it's not, there's no adenoma, excluded adenoma, right? It's a
Yeah.
secondary hyperpara.
Yes, we have done systemic scan and CT neck for this young man, and we didn't find any adenomas. And that is the systemic on the left, and that is the CT neck on the right. It was completely free.
Right. Yani the fact is that we see so many people, patients with secondary hyperpara, but the brown tumor is rare. Why do you think he developed brown tumor in this case?
I don't get your question, please, my professor.
Why do you think, despite of the fact that secondary hyperpara is very common in end-stage renal disease on dialysis, why did this particular patient develop brown tumor?
I didn't get any clues. Even I had logged into other pathologies like Paget disease of the bone, but I had revoked it because the young age Paget disease we know occurs in
older age,
early above 50 years, and always the picture giving a mixed osteoclastic and osteoplastic activity on pathology, and it wasn't the case. Even on gross looking for the tumor, it was fleshy with bone fragments. And in the MRI, it also appears fleshy.
It's multiple, the clavicle and the spine, right?
Yeah, what?
It's multiple, not one tumor, one in the clavicle and one in the spine.
Yeah, one in the spine.
It's unusual.
Yeah, it is unusual to get two rapidly developing, and the clavicle occurred first of all and didn't do anything, and we didn't notice this deteriorating effect unless the patient developed acute flaccid paralysis within 2 weeks. All this course is within 2 weeks.
2 weeks.
And this appeared after 6 months of his hemodialysis course.
Yes.
But I expect this patient has a long-standing chronic renal failure.
Yep. So
he has nephritic bladder and pyelonephritis. So maybe this bone disease was many years before, or is that true?
Yep, I agree with you that he stands many years in chronic kidney disease before presenting to the hemodialysis, which we can add to the duration of his metabolic profile.
Yes.
Yeah.
Any other metabolic abnormalities for this patient? Because this is a young patient has a neurogenic bladder. Is there any anomalies like that? Congenital anomalies?
No. The patient when screened for factorial, there is no another congenital lesions for this patient.
Okay.
And as you see, we have screened it with echo. We always screen a patient for echo before starting hemodialysis as a standard procedure for admitting patients in our unit. and his echo failed to identify any congenital lesions.
Yes,
Oh,
very interesting actually. So despite the low level of BTH and this development of different tumors in different parts in the body, and this is considered as a parathyroid origin or due to hyperparathyroidism in this case.
Yes.
Yeah.
And I'd like to add, if you look clearly to this view, lateral view, there is no aortic calcification at all. Yeah, there is no aortic calcification at all if you are looked for lateral view within the abdomen or on the thoracic area. There is no calcification involving the vascular tree.
Yeah.
Thank you for this very interesting case where Dr. Saeed Khamis is commenting that is tumoral calcinosis. Do you have a comment, Dr. Saeed? And
yes, Dr. Yasser.
yes, please.
Thanks for Dr. Kishawi for this interesting case. I faced this few cases like this case, and actually, from my point of view, it is not a brown tumor. Maybe I am wrong, but it is, from my point of view, it is a tumoral calcinosis or what's called the Touch-Lander disease. It's some sort of soft tissue calcification, very articular soft tissue calcification, usually occurs in the underdialyzed cases of hemodialysis, or sometimes in the long-standing hemodialysis patient due to disturbance, as Professor Kishawi said, phosphorus, calcium, and PTH. But it is not the role that PTH should be high, or calcium should be high, or phosphorus should be high. Sometimes they are normal, and the patient develops this what's called tumoral calcinosis. It is completely different from brown tumors, and it regresses with the intensification of dialysis and control of calcium, phosphorus, and PTH disturbance. This is my point of view. This is a tumoral calcinosis rather than a brown tumors of the bone.
Thank you.
So
Thank you,
bone
Saeed.
biopsy may have a role in this case as the bone biopsy.
This is a question. This is a question from Dr. Mahmoud
Yes.
Sheikh also
Yes.
on the chat about bone biopsy, role of bone biopsy. He says that bone biopsy may be mandatory in this case, as it seems mixed osteodystrophy, and this is his comment that we can need a bone biopsy for a distinguish. Please, Dr. Saeed.
I think Professor Kishawi, the patient underwent already bone biopsy or not? This from the removed tumor.
He didn't done a bone biopsy. Didn't done a bone biopsy, despite it seems indicating, especially after occurring of rapidly bone softening disease and scoliosis after the surgery. Which I think by the guidelines, rapid loss of the bone density, I think as an indication for kidney biopsy, for bone biopsy.
Yeah, even if we suggest this, what's called the tumoral calcinosis, it's not mandatory to have a biopsy from the lesion. I mean, this calcified soft tissue or this very articular calcified soft tissue lesion. There is no need for this by imaging and history, and usually it regresses with intensification of dialysis and the control of calcium phosphorus disorder.
Thank you.
So I am with the tumoral calcinosis rather than brown tumor. I don't know what
thank
the
you, Professor.
of Dr. Kishawi and Dr. Dawlat and Dr. Hamdi.
We have done, we take brown tumor depending on the pathology. Because he described the sections typically by the book, as we see, he described a case of osteoclast type giant cells with a fibroblastic background with reactive, poorly calcified woven bone tubercle. So we didn't question the pathology.
Yes, right, you are. So this is from the lesion. This is from the lesion, the pathology report.
Yeah, this from the lesion.
So it is a bony tumor rather than it is a very articular tumor. What is the answer?
Yes, the neurosurgeon said that it arises from the body of T10. That is the comment of the neurosurgeons interoperatively.
But what about the clavicular lesion? It is from the bone or periarticular?
No, from the bone, from the clavicular head. I will see you immediately. That is from the bone, as you see.
But I heard you told it is Felici rather than hard lesion.
The lesion retrieved from T10. T10 this mass, the clavicular head, didn't we operate? We left it for spontaneous regression.
Yeah. I mean clinically. It is Felici or
It is hard. No. This mass was very hard. It is bone. Yes, I will see.
Okay.
It is yes. This is after regression, but this was bone.
Okay.
Yeah.
Okay. Thank you for this nice discussion. Before we go to the second case, thank Professor Said Khamis, and Professor Hisham Said agrees with you totally in having no biopsy. Before we move to the second case, we have a comment from Dr. Gamal Tawfiq, and we have a question on the chat from Dr. Ibrahim. So please, Dr. Gamal, unmute yourself.
السلام عليكم.
وعليكم السلام ورحمة الله.
عليكم السلام.
طبعا الحاله فيري انترستنج كيس يا دكتور خشاوي، بس انا عندي نقطه. الراجل ده هل كان عنده كايفوسكلوروزس قبل الموضوع ده؟ صعب جدا انه يبقى في خلال اسبوعين يعني يحصل الكايفوسكلوروزس اللي عنده.
لا يا فندم، عشان كده انا جبت صوره I saw this picture intraoperatively. The spine is straight as you see. That is the intraoperative by
بس
open eyes.
الصوره دي من فوق لتحت ما تبينش اللاتراليتي بتاع السباين.
اوكي you can see.
يعني انت لو شايف ايوه دي مثلا اهو السباين كويس ستريت اهو.
Yes, straight. And in this
هل عدتها بعد كده؟
yes, this X-ray here 2 weeks later this we found
مش دي قبل الاوبريشن؟
لا after the operation 2 weeks after the operation.
دي افتر اوبريشن. وفين اللي قبل الاوبريشن؟
بعد الاوبريشن يا فندم. after the operation.
ده فين اللي قبل الاوبريشن؟ انا عايزين نشوف اللي قبل الاوبريشن. هل فعلا كان
this MRI يا فندم.
مش واضح.
اوكي.
ماشي يا قشاوي، شكرا.
اوكي. Thank you.
Thank you.
Dr. Hisham Said says that tumor calcinosis by X-ray there is intense calcification. Not in this case. And from Dr. Ibrahim Omar, he is asking about what is the origin of parathyroid tumor in the spine. Is it primary or secondary? Then what is about the neck? What about the neck and the parathyroid evaluation?
I had disclosed this, that neck CT scan didn't reveal any adenomas, and that is a STEMI scan on the left also failed to detect any.
Okay. Dr. Said Khamis is thanking you. And we also thank you, and thank you for this case, Dr. Kishawi and Dr. Hamdi. Please, Dr. Hamdi.
طيب أنا هقدم I will introduce Dr. Diana Charles, our newest lecturer of nephrology. She's the first one to get nephrology MD in Suez Canal University. And I expect the presentation and nice case. Dr. Diana.
Thank you, Professor Hamdi. First, I would like to thank Professor Yasser and Professor Hamdi for such a great opportunity. And I'm also so grateful to present a case discussion with Professor Dawlat, of course, and the most eminent nephrologist. The case is titled about "It's Never Too Late to Revise Your Steps." It's about a 46-year-old male patient, lives in Ismailia, in a rural area in Ismailia, married with 2 offspring. He's a farmer, no special habits of medical importance, no history of smoking or alcoholism. Patient presented to our nephrology department with 1-week history of bilateral lower limb edema, a skin rash evolving for 5 months with a rise in his baseline serum creatinine. His medical condition started since 2015 when he was diagnosed with hypertension and chronic kidney disease due to membranoproliferative glomerulonephritis after doing a renal biopsy. His serum creatinine at the time was 2.3 milligram per deciliter. He sought medical advice and was prescribed steroid therapy for idiopathic MPGN. Then he was maintained on oral prednisolone 20 milligram daily, as well as calcium channel blocker and beta blockers for hypertension. Since that time, his condition remained stationary with a baseline serum creatinine about 2 to 3 milligram per deciliter and persistent proteinuria within 1 gram per day in his follow-up labs. When he presented to our department, he presented with progressive deterioration of his kidney function. Serum creatinine at that time was 5 milligram per deciliter, bilateral lower limb edema for 1 week duration with gradual onset and a progressive course, which extended up to knees. He also complaining of itchy skin lesions, vesicles on his legs, which started 5 months ago with progressive course. No other cutaneous or mucocutaneous lesions. Review of other system was irrelevant. Regarding his past history, he was diagnosed 1.5 years ago with cutaneous lichen planus, and MMF was prescribed by the dermatologist with a daily dose of 1,000 milligrams. Partial remission was occurred within 6 months, and then MMF was stopped. No other considerable morbidities and no family history of kidney diseases. On examination, patient was fully conscious, lying flat, no dyspnea or orthopnea. Blood pressure was a little bit high, 160 over 95 millimeter mercury. Pulse was tachycardic but regular, and temperature was 37.6. No abnormality detected in chest or heart examination. Abdomen showed dullness in trops area, but there is no ascites. As shown here, the legs show bilateral lower limb edema extended to the knee. It's a pitting edema, and there is a dark brown hyperpigmented skin lesion with vesicles. Dermatology consultation revealed necrolytic acral eczema or lichen planus secondary to exfoliation. The finding at that time, hemoglobin was 8.5 milligrams, normocytic normochromic anemia. Serum creatinine was 4.5, uric acid is high, 11 milligram per deciliter, albumin 2.8, albumin creatinine ratio 4,500 milligram per gram, calcium was low, 6.6, phosphorus was 8.1. EBG show mild compensated metabolic acidosis, urine analysis show albuminuria, pus from 20 to 30, RBCs over 100. The abdominal ultrasound show features suggesting of liver cirrhosis. So irregular surface, irregular hepatic vein, as well as dilated portal vein reached 17 millimeter, and spleen was enlarged 20 centimeter. There is minimal intraperitoneal free fluid collection, and both kidneys show echogenic grade 2 with reduced corticomedullary differentiation, and there is a few simple cortical cyst bilateral, as well as lower calyceal stone. At that point, we faced some questions needed to be answered. Is it a case of chronic kidney disease due to chronic glomerular disease? Is it a real case of idiopathic MPGN? Or we need to know the underlying cause and doing further investigation? What is our plan of management at that time? Do we need to continue steroid therapy? Our plan is first to revise his renal biopsy, which done in 2015, and to doing further investigation regarding his MPGN. At that time, we decided to stop steroid therapy and also to revise his liver condition. We decided to control his blood pressure and treat UTI as a short term. Regarding rebiopsy, we consider it is not suitable for this patient because of echogenic kidney and with multiple cysts. On revising the renal biopsy, there is 17 glomeruli, out of which none was obsolescent. Glomerular basement membrane, so moderate thickening with duplication. endocapillary proliferation, having frequent neutrophils, xylus tubule, mild atrophy, and interstitium fibrosis, about 20%. And immunoperoxidase show IgG deposits within the glomerular basement membrane. As we all know, MPGN is not a disease entity per se. It's a pattern of glomerular injury on kidney biopsy, characteristic by lobular formation with endocapillary proliferation and duplication of the glomerular basement membrane, which appear as drum track appearance by silver stain. MPGN pattern of injury was classified before as 3 classes. Its old classification is dependent on the site of immune complex deposit. But now, the Mayo clinical classification divided MPGN into 3 broad pathogenic pathways. It's divided into first class, it's immune complex mediated. Second class is the complement mediated, or third class where there is negative immunoglobulin and negative complement. In immunoglobulin mediated, immune complex mediated MPGN, it's maybe a result of chronic infection due to viral infection, hepatitis B or C infection with or without cryoglobulinemia, as well as bacterial infection, protozoal infection like malaria or schistosomiasis, as well as maybe a result of autoimmune disease or a monoclonal gammopathy or idiopathic at the end. Returning back to our case, it's immunoperoxidase show only immunoglobulin G deposits. So it's a case of immune complex mediated MPGN. So we decided to do further investigation. Stool analysis was not conclusive, show intermediate histolytic assist. ESR first hour was 48, CRB 85. Hepatitis C, B, and HIV serology all are negative. Hepatitis C, BCR also was negative. Immune marker was done, all are negative except weak positive for ANA. C3 was low normal, C4 was normal, cryoglobulin in serum was negative, total protein was normal. We do upper GI endoscopy to assess his liver condition. Unfortunately, there is no esophageal varus. So we decided to do rectal snip to searching for bilharzia as the patient is a farmer. In fact, there is a calcified bilharzial ovum with granuloma formation. So it's a case of MPGN secondary to chronic bilharzial infection. We decided to treat patient with, first we stopped steroids. Steroid therapy was discontinued at that time. Antiparasitic treatment was added, parasequental 20 milligram per gram per day in 3 divided doses for 1 day. ACE inhibitor for his proteinuria, as well as diuretics. On follow-up the patient after 1 month, unfortunately, there is no improvement of his renal function, but there is decline in the level of albumin-creatinine ratio. Schistosoma nephropathy was caused by Schistosoma mansoni and japonicum, are the 2 main species for gastrointestinal schistosomiasis. Clinically, it may passes by different stage, acute, subacute, and chronic stages. Immune complex deposition was reported as the main mechanism mediating most of glomerular damage in schistosomiasis. The afferent classify schistosomal nephropathy into 5 classes. The third class, membranoproliferative, was the most prevalent form in schistosoma infection. And it's associated with hepatic cirrhosis and high IgE level, as well as they present with nephrotic syndrome and the progressive decline in renal function. Here is an article published by Professor Rashad Barsoum, God bless his soul, in International Kidney. He concluded that progressive renal insufficiency is common in class 3 and 4 schistosomal nephropathy, and the disease cannot be modified by any current treatment, including antihelminthic drugs, steroid, and immunosuppressive agents. Another study by the title of Schistosoma mansoni-induced mesangoglomerular nephritis, influence of therapy, they concluded the same. It concluded that MPGN in patient with hepatosplenic form of schistosomiasis is a progressive disease. not influenced by antiparasitic or immunosuppressive therapy, and present in a clinical course similar to idiopathic form of MPGN. So it's a little bit controversial, but some study shows that renal lesions are irreversible. However, specific antiparasitic treatment can alter the renal disease development or progression when instituted in the initial phase. While patients with proliferative form do not respond to antiparasitic treatment nor to immunosuppressive, suggesting that this type of glomerular involvement has a progressive pattern. While KDOQI guideline in 2021, they propose some recommendation is to treat patients with schistosomal infection with appropriate antiparasitic infection in appropriate dose with appropriate time and duration, and there is no indication for use of immunosuppressive agent in schistosomal nephropathy. They also added that in the management of MPGN, there is no need of steroid therapy except in specific idiopathic form of MPGN with specific condition, when there is crescenteric form in the renal biopsy or in presence of active urine sediment. And when the cause of idiopathic glomerulonephritis is determined, the initial approach to treatment should focus on the underlying pathological process. And most of cases, it's best to be managed with supportive care and carefully considered use of immunosuppression. And they added that most of patients with idiopathic MPGN presenting with Smith-GFR below 30 milli per minute treat with supportive care alone, as that means there is no need for immunosuppression or corticosteroid in such cases. They added another point that schistosoma with endemic co-infection like hepatitis B or C or HIV, it should be treated because treatment may alter the aggressiveness of the underlying glomerular disease or the sequelae of schistosomiasis, because it is associated with more rapid progression to cirrhosis or liver carcinoma. Here is a study about the high prevalence of occult hepatitis C viral infection in patients with primary and secondary glomerulonephropathy. They concluded that about 40% of patients with immune complex mediated glomerulonephritis was positive for occult hepatitis C. Occult hepatitis C is characterized by hepatitis C RNA in the liver or peripheral blood mononuclear cell in a patient with negative test for hepatitis C RNA, with or without the presence of hepatitis C antibody. Occult hepatitis C is a potential culprit in cryptogenic liver cirrhosis. So the gold standard for occult hepatitis C is liver biopsy or examination of peripheral blood mononuclear cell. Another study about MPGN caused by an apparent or occult hepatitis C infection. They concluded that liver cirrhosis and concomitant MPGN should arouse suspicion of hepatitis C infection despite negative results from serological analysis. At the end, my take-home message was the presence of immune complex mediated MPGN, necessity evaluation for infection, autoimmune disease, and monoclonal gammopathy. Please search for the underlying cause before saying it's an idiopathic form. Management of MPGN is supportive care except for specific situation. Test for endemic co-infection, which may alter the sequelae of schistosomiasis and the glomerular disease outcome. Liver biopsy is a gold standard test for occult hepatitis C. Here's another question needed to be answered. And finally, again, it's never too late to revise your steps. Thank you.
Thank you, Dr. Diana, for this very interesting case. Dr. Dawlat, you can unmute yourself, please.
Yes, سامعني كده يا ياسر?
Yes, it's clear.
Yes. Thank you very much, Dr. Diana. It's a very, very interesting but perplexing case. And the occult hepatitis C is a very attractive option because there must be a reason for what is happening in the kidney. it's true we cannot put our finger on the reason, and we always call this primary or idiopathic or essential, but there must be a reason. What was the finding of the ultrasound or CT for the liver? Can be liver cirrhosis?
Yes, there is feature of liver cirrhosis with dilated portal vein and splenomegaly, but there is no periportal fibrosis or portal hypertension.
So would you go for, what will happen if you go for a liver biopsy? Are we going to test for hepatitis C, the antigen?
I think
the liver, okay? This occult hepatitis C means that the antigen is inside the liver, not in the peripheral blood.
Exactly.
So if we take a biopsy, are we going to do a PCR for the biopsy?
I think we need to ask our colleague, our gastroenterologist colleague, but
right.
from the studies,
Professor Dawlat, can I ask that if we found HCV inside the liver and no PCR, I think this patient will not be a candidate for antiviral treatment. So the liver biopsy would be of value there, here?
I suppose you're right. It's just for diagnosis, for finding the truth what's going on in this patient. And we have so many cases of bilharziasis. Why should one proceed to have this very destructive MPGN? And most of the people don't. And we have so many people with HCV and so many people with periportal schistosomal fibrosis. What is the difference in this patient? I would like to know, يعني.
Do you have a comment, Dr. Hamdi? Professor
yeah,
Hamdi?
it's not unclear. Yeah, exactly. So the liver is cirrhotic liver, so I don't think that the biopsy will add because it is a cirrhotic liver already. So I don't think that the treatment will add for this patient, this part. And regarding the combination of bilharzial effect of on glomerulitis, so it is one of the possibilities that we found that it is bilharzial schistosoma granuloma, which is found in the rectal snap, maybe associated with this is the case of. But it is in this case we have a chronic renal failure patient that maybe we are a little bit late to try to help this patient because already small kidneys and echogenic and already have elevated serum creatinine for a long time. So it's not an easy case to handle or to manage. This way, I think.
For the discovered pathology of MPGN, I think this patient was lucky to have a secondary MPGN, not primary. If you have a cause, you can treat the cause. But I think he was presented too late for you. If this was a representation, this can result in improvement of the condition, especially in the face of new treatment for hepatitis C and the easy treatment of schistosomiasis now. You received,
and also the treatment for hepatitis C now, which is like nephrotoxic a little bit also. This another way.
You received, Dr. Diana, you received many congratulations from the staff, Professor Saeed Khamis, Professor Manal Adib, Professor Hisham Al-Sayed, and I think Professor Hisham Al-Sayed wants to have a comment. Unmute yourself, please.
Thank you very much, Diana.
Thank you, Doctor.
It's a newborn star in the Suez Canal Road.
Thanks, Prof.
Yes, it's always newborns in Suez Canal, usually, yes. Thank you again. It's a dilemma because of the, you know that if you are treating aggressively all the bilharziasis, you aggravate the immunological disease of the kidney. So I think there is additional biopsy. What I was wondering that there is no esophageal varices. So perhaps there is some sort of portal vein thrombosis by Doppler ultrasound you can achieve, because mostly of patients with that huge splenomegaly at 20 centimeter without esophageal varices should highlight another pathology in the portal vein. to my opinion, I have to seek against hepatitis C. I have to seek again rheumatoid factor for possible cryoglobulin. We all know that cryoglobulin is not in each lab we can find, but sometimes it's hidden beside some of the, I agree that the lesions, skin lesion is not typical of cryoglobulinemia. For such a patient, liver biopsy will be of value if planned for further liver transplantation. Otherwise, it's not. In all case scenario, patient of CKD and should be conserved.
Can I
Okay,
have Professor Hisham? Sometimes the cryoglobulins are consumed in the lesion. You find a negative result not only due to lab error. Lab error is very common to assess cryoglobulinemia, but sometimes the cryoglobulins are consumed in the complex itself, and you get a negative result.
Yes, I agree. I fully agree with you, Professor Dawlat, for
It's like
sure.
in DIC, a consumption coagulopathy. It's the same explanation. But this is definitely a lichen planus, which is very common in hepatitis C.
But not due to cryoglobulinemia?
No, it is not due to cryoglobulins.
Yes,
No.
exactly. It's a extrahepatic manifestation
Yes.
of hepatitis C, but not related to a typical rash of vasculitic rash of cryoglobulinemia. So we can do rheumatoid factor because sometimes you can find a high titer for rheumatoid factor in such a case, may be highlighted. In all case scenario, it's an end-stage disease, and the plan for liver transplantation should be guided by FibroScan and liver biopsy.
What about the
I have a small comment, please, Professor.
Sure.
Oh, okay, sure.
Yeah, the skin lesion didn't take the typical presentation and typical distribution of cryoglobulinemia. It present only in both legs, as well as there is no other features of cryoglobulinemia, including arthralgia or arthritis. And we did cryoglobulin in the serum, and it was negative.
And moreover, Dr. Mahmoud al-Sheikh adds in the chat that will be consumption of C4, which we all know for cryoglobulinemia to cause. No, you have normal C4.
Yes, C4 was normal.
So thank you for this.
One question, Dr. Yasser, I would like to thank Dr. Diana first. And the second, my question, the anti-GBM, or sorry, the IgG deposition, it was the linear in the GBM or no?
There is no specific pattern was mentioned in the biopsy, actually.
Okay. Second question, why didn't you take biopsy from the skin lesion?
It's a brilliant question, actually, Prof. Said.
Dermatology,
our colleague of dermatology didn't recommend that, actually. They see it's a case of lichen planus as a patient has all the history already of a lichen planus.
Okay, usually, it could be a clue. I mean,
usually,
the biopsy can be a clue to this dilemma, you know.
Exactly.
There are some rare diseases can affect both kidney and the skin, like, and they have the same picture, like what's called the leukocytoclastic vasculitis or hypocomplementremic leukocytoclastic vasculitis also. But already complement is okay, I know here.
Professor Said, usually dermatology do not do biopsy if they can diagnose the lesion by
clinical exam. Oh, yeah.
Spot diagnosis.
By the examination.
Yes.
I think if a spot diagnosis, they do not do a biopsy.
Okay.
Not to be mismatched for any other lesion.
Right, you are. I'm still in doubt, Dr. Diana.
By examination, they usually do not go to biopsy.
Yeah, right, you are.
Thank you.
Dr. Diana, I am still in doubt. There is no causal association, actually. I know that, as you said, schistosomiasis can what's called lead to MPGN, okay. But we cannot swear that is the reason, the cause for this disease here. Maybe it's just coincidence, okay? And back again to the primary MPGN or the idiopathic form. I wondered you didn't do the fundus examination to rule out the extra renal manifestation of MPGN, like the drusen or deposition of this pigmentation in the brush border of the retina? And second, is this patient clinically has facial lipodystrophy or what? I mean, the extra renal manifestation of MPGN. What do you think?
No, doctor. There is no other facial features regarding C3 glomerulopathy or dense deposit. No, there is no feature. But regarding the first question, is it the case behind the MPGN pattern is behind schistosoma only? I don't think so. I still think there is a co-infection with hepatitis C, which is occult. So I emphasize on that point at the end of my presentation.
Or maybe ojibas. No one can guarantee because
okay.
no one can guarantee because there is no difference in the biopsy. Actually, you cannot.
I think the clue will be in the liver pathology. Because we have to focus on the liver biopsies that may explain the renal pathology. So I think it's mandatory to adjust PT and PTT, platelet count, everything, and ask. It's a simple procedure to have a liver biopsy, and you can see that the pathological finding may have hepatocyte injury, necrosis, which is not a hallmark of bilharziasis.
Right.
So that's my opinion, and it will be further for probable liver transplantation for this patient, or combined liver and kidney transplantation, actually.
But we cannot deny it's a very interesting case, Dr. Diana. Thank you for this excellent presentation.
Can I have a comment, please?
Okay.
Yes.
All right. Occult HCV is a very attractive.
Thank you. Thank you, Dr. Diana, for this.
Professor Dawlat is talking.
Just one last comment. Why don't we go simple? If this person had,
I think Professor Dawlat.
Yes, if he had schistosomiasis, which affected his liver, and it's periportal schistosomiasis and periportal fibrosis, and schistosomiasis of the kidney causing MPGN. And the lichen planus should not be the main factor to direct my diagnosis. What are the other causes of lichen planus? I mean, we have one single pathology, one single reason that can affect both the kidney and the liver in this patient. And lichen planus can be for another cause. It's very interesting to connect the lichen planus to hepatitis C. But
absence of
association.
Absence of vosogenial varices in this patient. I don't feel that it's bilharziasis.
Will be conclusive, Biopsy will be conclusive. Periportal fibrosis due to bilharziasis, and the kidney is MPGN due to bilharziasis. Lichen planus can be for another reason.
We don't have esophageal varices, which is very common with bilharziasis. So I doubt that bilharzia liver disease.
Okay. Okay.
Thank you very much.
Thank you very much, Diana. I think the main issue here, we need all, and Professor Manad Deep say that we need a liver and a skin biopsy. And for me, I find this finally will lead to only diagnosis and no treatment decision. And it's very difficult for to do a biopsy from a cirrhotic liver. It is very difficult and very dangerous.
Right.
Very dangerous.
Yes.
Right.
So thank you for this interesting case, and thank you, Professor, for the very nice discussions.
Prof.
Hamdi.
This is a new star also in Suez Canal University, the nephrologist. She will be the second MD in nephrology soon, inshallah. So I expect her also to give us a very good presentation and a very nice case for the doctorand.
Well, thank you, Professor Hamdi, for giving me this opportunity. It's a pleasure to introduce this case in front of an elite of pioneer professors of nephrology. Well, starting with the history, he is a 38 years old male patient, smoker, married, has 3 offsprings, live in South, work in dive fishing in Marsalam. The patient came to us complaining of anorexia, vomiting, and oliguria of 1 week duration. Our patient was fit and well till 1 week before presentation when he started to have bilateral lower limb numbness and weakness after diving at a distance of 35 meters below the sea level during daytime and with his ordinary exerted effort, but it was a longer dive. Additionally, nothing was mentioned about the rapidity of his ascent. A trial of using hyperbaric oxygen was done with improvement of the numbness and weakness. However, he started to have headache, shoulder pain, and myalgia. 3 days later, our patient started to have anorexia, vomiting, oliguria. He denied any change in urine color, and he had class 3 dyspnea. He sought medical advice when the physician ordered some labs, which denoted that his serum creatinine was 7 milligrams per deciliter, with no prior history of any renal impairment. At the time, the patient was referred to our hospital. To be noted, no history of fighting by any sea creature, also he is not on any medication. Review of other systems revealed no abnormality. Past and family history are irrelevant. Examination and the time of examination revealed that the patient was conscious, alert, oriented. His oxygen saturation was 97 on room air, blood pressure 150/90, afebrile, with a urine output of 300 cc over 12 hours. Respiratory rate and pulse was normal. His GVB was raised. Chest examination showed bilateral basal diminished breath sound. Cardiac examination, abdominal examination, and the neurological examination were unremarkable. Bilateral beating, non-tender, lower limb edema up to knee level with no tense cuff muscles. Both thighs showed ecchymotic patches and laceration marks. Lab before presentation shows that his serum creatinine, blood urea, serum uric acid, ALT, and AST were elevated. On presentation, his creatinine was 12 milligrams per deciliter, sodium 126 milligrams per deciliter. He was hyperkalemic also, with potassium 6.5 milligrams per deciliter. ALT, AST was elevated 281 and 347. His D-dimer was 6,000. His CK level was 15,750. His albumin was 2.6 milligrams per deciliter. Phosphorus was 8.2, uric acid 11.2. His VPG showed metabolic acidosis, and urine analysis showed the presence of RBCs 0 to 5, BUS 0 to 5, protein +1, myoglobin positive. It was 15 microgram per milli. Other investigations, ECG, hyperacute T wave, CT chest showed bilateral mild to moderate effusion. His pelvic abdominal ultrasound showed minimal to mild intraperitoneal free fluid collection with average size liver, bilateral average size kidney with echogenicity grade 1. IVC diameter was 2.5 centimeters, which is dilated. Doppler study of both lower limbs, subcutaneous edema, and no DVT. About the course in the hospital, after giving calcium gluconate for cardiac stabilization in ER, patient was started on hemodialysis. 5 sessions were performed with ultrafiltration. Oliguria improved gradually, with gradual improvement of the renal function and CPK level. Patient discharged from hospital after stabilization of his general condition with hemodialysis catheter removed and to be followed up 1 week later. Follow-up after 1 week showed that his phosphorus level back to normal, uric acid back to normal, creatinine from 12 to 3.5, sodium back to normal, potassium is 4, ALT and AST decreased, CK level decreased from 15,750 to 255, MB level from 140 to 11, and D-dimer from 6,000 to 1,000. Our differential diagnosis goes around that it's a rhabdomyolysis induced acute renal failure as a result of decompression sickness or excessive exertion. Our professional diagnosis was a case of rhabdomyolysis induced acute renal failure as a result of decompression sickness. Going through some scientific background, rhabdomyolysis by definition is a syndrome caused by injury to the skeletal muscle and involves leakage of large quantities of potentially toxic intracellular contents into the plasma. First described in the victims of crush injury during World War II. About the pathophysiology, the lysis of cell membrane releases organic and inorganic intracellular components such as myoglobin, potassium, lactic acid, purine, and phosphate, which enter the circulation after restoration of the blood flow. When reperfusion starts, leukocytes migrate into the damaged area, cytokines and prostaglandins increase, whereas free radicals are produced in the presence of oxygen. Myoglobin, which is a 17 kilodalton small chromoprotein like hemoglobin, they are post-filtered through the glomeruli and reabsorbed in the proximal tubules by encytosis. In acidic environment, the globin chain dissociates from the iron-containing ferrihimate portion of the molecules. This normally happens in lysozymes where free iron is rapidly converted to ferritin. However, in rhabdomyolysis, the amount of myoglobin delivered to the proximal tubule cells overwhelms their ability to convert iron to ferritin, resulting in intracellular ferrihimate accumulation. Iron as a metal has the ability to donate and accept electrons, as well as the capability to generate oxygen-free radicals. This leads to oxidative stress and the injury of the renal cells. Myoglobin cannot be reabsorbed when in excessive amounts in the tubules, which in turn increase myoglobin concentration in urine. The latter causes formation of casts that obstructs the renal tubules. Besides iron toxic effects, the heme center of myoglobin initiates lipid peroxidation and renal injury. Therefore, the obstruction of renal tubules by myoglobin causes the formation of free radicals from iron. The vasoconstriction of hypoxia due to hypovolemia are the main causes of acute renal failure in rhabdomyolysis. The etiology may be related to trauma and muscle compression, infections such as viral infection like influenza type A, B, which are the most common, COVID-19 as well, bacterial infection like Legionella, Salmonella, fungal infection as well. Maybe metabolic and genetic factors, genetic muscle defects which are related to the inability of the muscle to use ATP or because inadequate ATP production. The mismatch of energy supply and the demand may result in disruption of the cell membrane. Also, electrolyte derangement, hypophosphatemia, hypokalemia, hypernatremia, and hyponatremia, and some metabolic disorders like thyrotoxicosis, pheochromocytoma, diabetic ketoacidosis, hyperaldosteronism, and Addison disease. Drugs and mytoxins as well, as you can see. Other causes like exertional activity, such events often occur under extremely hot or humid conditions and are related to exertional heat stress and heat stroke. One of the factors that increase the risk of exertional rhabdomyolysis and renal failure include dehydration. There is a specific etiology in our case, which is a decompression sickness. A scuba diver at a depth greater than 7 meters may accumulate a tissue partial pressure of nitrogen large enough that, on ascent to the surface, nitrogen exits tissue rapidly, forming bubbles in the blood and other organs, which is known as decompression sickness. Also, this bubbles disorder can, in theory, cause injury to the skeletal muscle. Our case demonstrates the potential for massive muscle necrosis after decompression injury. The incidence of decompression syndrome sickness, fortunately is rare. The incidence among the commercial divers can be higher, ranging from 1.5 to 10 per 10,000 dives. The incidence depends on the length, the depth of the dives, also rapidity of the ascent. The risk of decompression sickness is 2.5 times greater for males than females. So regarding the tissue damage, which result from multiple mechanisms like the blockage of the blood flow and the vascular spasm, the gas bubble itself, which cause endothelial injury, inflammatory mediators which are released, increase the endothelial permeability, lead to the development of edema, which lead to tissue ischemia. Decompression sickness occurs most frequently in shoulders, elbows, knees, and ankles. Joint pain account for most cases, with the shoulder being the most prevalent site. Neurological symptoms present in 10 to 15% of decompression sickness cases, with a headache and visual disturbances the most common symptoms. Skin manifestations are features as well in about 10% to 15% of the decompression sickness cases. Larger numbers of bubbles in the venous blood may cause lung damage, and bubbles involving the spinal cord function may lead to paralysis, sensory dysfunction, or death. The diagnostic confirmation is if the symptoms are relieved by recompression in hyperbaric chamber, as in our case. The treatment of decompression sickness is 100% oxygen, followed by recompression in hyperbaric chamber. In most cases, this will prevent the long-term effects. To prevent the excess formation of bubbles leading to decompression sickness, divers limit their ascent rate. Recommended ascent rate used by popular decompression models is about 10 meters per minute. The clinical presentation by the history of the classic triad of rhabdomyolysis of myalgia, generalized weakness, and darkened unit. In practice, however, the presentation of rhabdomyolysis varies considerably. The classic triad is actually seen in only about 50% of the cases. Additional non-specific symptoms may be there as well, like fever, fatigue, nausea, and vomiting. Physical examination may be non-specific. We could find some muscle pain tenderness, decreased muscle strength, soft tissue edema, some skin changes consistent with pressure necrosis, maybe a tense and tender muscle compartment, which suggests compartment syndrome. But if evolving rhabdomyolysis is suspected based on the clinical scenario, an appropriate laboratory evaluation should be performed to diagnose muscle damage and organ dysfunction. The complications are hyperkalemia, hypocalcemia in the start as a result of deposition of calcium phosphate or decreased level of 1,25-dihydroxycholecalciferol, and later on hypercalcemia due to calcium leakage from the damaged muscle. Hypoalbuminemia, hyperuricemia, compartment syndrome may be either a complication or a cause. Acute kidney injury occurs in 17 to 35% of the adult patients, AKI and DIC as a complications, renal failure. Investigations include CBC, including hemoglobin, hematocrit, and platelet, blood urea nitrogen, and other electrolytes like creatinine, calcium, potassium, phosphorus, uric acid, and the liver enzymes, LDH. Regarding CK, the peak CK level, especially when it's higher than 15,000 units per liter, may be predictive of renal failure. Carbonic anhydrase 3 elevation is the most specific marker for muscle injury, but the method is difficult and expensive. Aldolase, lactic dehydrogenase, and the transaminases, ABG, functional excretion of sodium in urine, more than 1%. Urine dipstick may sometimes show a positive for blood while with absence of RBCs in the urine, which suggests myoglobin, and the myoglobin level in urine analysis. CT, MRI. MRI is considered the imaging modality for choice for evaluating the distribution and the extent of injury of the affected muscle, especially when fasciotomy or involvement of deep compartment is considered. Additionally, may shows the eight pupils in our case. ECG, the compartment pressure as well, muscle biopsy if I'm suspecting an inherited muscle disease. The management is all about prevention and the treatment of acute renal failure with fluid resuscitation, maintaining the urine output from 100 to 300 milli per hour. The ideal fluid regimen is quite controversial. The initial administration of 1 liter isotonic saline and 1 liter dextrose 5%, to which 100 millimole sodium bicarbonate for alkalization of urine has been added is the ideal combination. As far as the patient maintain a urine output of 20 milli per hour, 10 milli per hour of mannitol, 15% can be added. As we know, mannitol can enhance the renal blood flow and the glomerular pressure, however, should be done under cross monitoring and must stop if a patient develops oliguria. Diuretics, if failed, IV fluid and mannitol, and also they potentially acidify the urine. Correction of the electrolyte, and the most important of them all are hyperkalemia, hypocalcemia, not treated if not manifested, hyperuricemia, and the hypophosphatemia are of clinical no significance. Dialysis may be required in patients with olivuric renal failure, persistent hyperkalemia, other electrolyte abnormalities, pulmonary edema, congestive heart failure, and persistent metabolic acidosis. About the role of the free radical scavengers and antioxidants in rhabdomyolysis like pentoxifalin, vitamin E or C, their clinical use remains unclear. About the prognosis, it depends on the extent and the clinical severity of rhabdomyolysis, as well as on the early and the prompt medical intervention. Some patients develop a mild renal impairment and recover quickly, whereas others require dialysis for more than 3 weeks. In most of the cases, the renal function is totally restored, and the general survival rate after rhabdomyolysis is 78.6%. Having had a decompression sickness may place patients at increased risk for future similar events. Prognosis is severity dependent and also dependent on such factors as the time to recompression, availability and the time to surface oxygen, and the supportive care. So health education to our patient is very important. My take-home message, early diagnosis and intervention is the key for treatment. It's essential to recognize the possible cause and limit it while coping with the pathophysiological complication of rhabdomyolysis. Thank you for your attention.
Thank you. Thank you, Dr. Nada, for this very interesting case.
Thank you very much, Nada, for this interesting presentation.
Thank you,
Professor Hamdi, your connection is not perfect. Professor Hamdi, can you hear me? Your connection is not perfect. Please correct your connection. Thank you, Dr. Nada. Dr. Dawlat, do you have a comment? We have some questions on the chat. Dr. Dawlat?
I mean, it is
Professor
mobile
Dawlat?
connection actually.
Okay. Okay, Professor Hamdi. تفضل. تفضل, Professor Hamdi, we are hearing you.
A little bit strange case. Yeah, do you hear me now? Do you hear me now?
Yes, clear. Go ahead.
Yes.
We lost you again. Unfortunately, we lost you, Dr. Dawlat.
But this a bit strange case because he is a usually dives, so he's a diver, and he usually dives frequently, and at that time maybe
what I can get that these patients usually dies. What I can get that these patients usually dies. It's a very interesting case.
Yeah. Regarding this patient, that make it like effect. Yeah, he's a dive. So it is,
okay.
So it is unusual that he's a dive regularly. Yes.
Okay, Professor Dawlat.
So
we have a question we have a comment from Dr. Mahmoud al-Sheikh.
Yes.
They say that the capillary leak sometimes we find in the CT multiple bubbles in the mesenteric and portal veins. And Dr. Nada, can you hear me?
Yes, Professor.
Professor Hisham al-Sayed asks about thyroid profile.
Well, can I know the point behind doing the thyroid
rhabdomyolysis. Hypothyroidism can cause rhabdomyolysis, can be a precipitating factor. We are wondering if this usually only due to decompression sickness, or there is an additional factor such as hypothyroidism, for example.
Well, we asked him about the symptoms of hypothyroidism, nothing about it, so we didn't go for doing the thyroid part, and it was quite clear from the history it needed to. Yes.
Can I have a comment, please? Yes.
Yes, Professor Dawlat. I think this was an important test to be done. It is a very simple test, and usually hypothyroidism not necessarily must have symptoms. Professor Dawlat, please.
Yes.
Professor Dawlat.
Well, Professor, I think there's something wrong with the connection.
Now you have a stable connection. Professor Dawlat.
سامعني يا ياسر كده؟
أنا كده سامع حضرتك دلوقتي.
طيب. I want to thank Nada for both reviews of the two different conditions, the rhabdomyolysis and the decompression sickness. But somehow I'm not very much convinced that the decompression sickness can cause this extensive rhabdomyolysis. For me, rhabdomyolysis mainly is exertion, severe exertion in very hot weather. This is what we always see, dehydration and heat strokes. And decompression sickness for me was always air embolism, or sometimes ischemic lesions in some isolated areas like the retina, but to the extent that causes ischemic necrosis of a huge amount of muscles ending in rhabdomyolysis is a little bit too, I don't know, not very convincing. There must be another reason why this
Yes.
diver developed rhabdomyolysis.
And this makes the question of Professor Hisham is very intelligent in asking about thyroid profile, another
Yes,
cause
sure.
that precipitates
sure.
in addition to
Doctor, can I have a comment?
yes, yes, Nada, please.
Regarding that, I mentioned that the confirmatory test for decompression syndrome was by putting the patient in the hyperbaric oxygen room, and if his symptoms started to improve, this is a confirmatory test. And our patient was put in the hyperbaric oxygen, and his numbness and weakness all disappeared after that. But he developed 2 or 3 days later the consequences, which indicates the presence of rhabdomyolysis and acute renal failure. So what makes it? So we put it in the first place because the patient improved on the first place on the hyperbaric oxygen, and this is stands strongly with the decompression sickness.
It makes sense. Yes, your answer is...
There's no doubt that he had the decompression sickness. He had it. And there is no doubt that he has rhabdomyolysis. But whether
we have...
the first thing caused the second, this is not very convincing for me, at least. I'm not so sure. How can all the muscles be affected with these bubbles causing ischemia and necrosis and rhabdomyolysis? There must be another reason with the decompression sickness.
Yes, Professor. It may be a double pathology.
Yes, in the stage of pre-treatment or pre-improvement, while you are treating this decompression sickness, how can you know that it will lead to complete improvement? I know that this was the situation, and the patient was very lucky upon your hands. But in the state of diagnosing and still we don't know, I think we are to do all the work up for rhabdomyolysis. In addition, as it seems somewhat strange reason for rhabdomyolysis, and this may be the reason behind you are presenting this rare case. Dr. Gamal Tawfiq wants to comment. Please unmute yourself. دكتور جمال بروفيسور جمال بليز. يس
ماشي. الشاب اللي قدمته الدكتوره ندى دون كان طبيعي جدا قبل الغطسه اللي هو، وده شغلته الحقيقيه في فناره تبع الاسماعيليه. شغلته هو وعيلته انه بيغطسوا في مرسى علم علشان يجيبوا اسماك نادره من تحت خالص، ومتعود على القصه دي. فمعنى ان هو يحصل له حاجه زي كده، احنا كنا خايفين ليكون حاجه عضته تحت او حاجه قرصته او يعني يكون تعبان ميه او سبايدر قرصته، بس هو ديناينج الحكايه دي خالص. وبعدين النقطه الثانيه ان الراجل ده بعد ما عملنا له دياليسيس 5 ايام الامور اتحسنت خالص، والاديمه كان جسمه كله منفخ، فالاديمه اتحسنت خالص والكرياتينين بدا ينزل. واخر مره كان من 3 ايام جالي كان الكرياتين بتاعه بقى 1.3، وكل الاديمه راحت ورجع تاني عايز طبعا يغطس تاني لان دي شغلته واكله عيشه. فطبعا احنا قعدناه شويه مع الطبيب النفسي شويه على اساس انه يحاول يفهمه الوضع بالظبط. وهي طبعا حاله انترستنج يا ندى، وشاكرين ليكي عليها.
Very interesting and
very nice,
very successful.
يعني you might be a pioneer to show the relation between these two conditions, maybe.
Yes.
Thank you, Professor.
I think to be written in a case report.
Yes.
Question from Dr. Ibrahim Omar. The question from Dr. Ibrahim Omar: what is the cause of acute liver injury and thrombocytopenia? And it was answered by Professor Saeed Khamis. Elevated transaminases is of muscle origin rather than hepatic one. Low platelet is mostly due to DIC. Do you agree with this?
Yes, Doctor, I agree with
Professor Hamdi.
I think so. I think we agree with that because in rhabdomyolysis you have increasing liver enzymes, and CK and all of these muscle markers. So it is It's very interesting also because you know that this patient denied any exertion.
Okay. Professor
No
Faisal,
more
thank you for
exertion.
coming. Professor Faisal Shaheen.
Thank you very much. It's very interesting case. And, you know, just I heard that probably can be some snake bite as well, which can cause all of this.
Yes, so Dr. Professor Gamal was wondering and was searching in the start of snake and snake bite under the sea. This was his first diagnosis before while taking history from the patient in the start.
So it's very interesting case and it's worth to be reported.
Yes, yes.
Well, Doctor, I have the comment to
Okay.
after Professor Said Khamis said that the elevated transaminases is of muscle origin. Yes, that's true because we did as well GGT and it was normal. So if it was a liver affection, the GGT may be raised. So it's here of a muscle origin.
Okay. Thank you for your response. Last comment from Professor Gamal Tawfiq. Unmute yourself, please.
عملنا الجي جي تي لقيناه نورمال، وده يفرق ما بين الهيباتيك انجري اكوت هيباتيك انجري اللي ممكن يحصل برضه نتيجه السندروم والماسل انجري اللي هو الفيتنج الانترانسامينيزيس بس اللي هي من الماسل اوريجن.
Okay.
شكرا.
Thank you. Dr. Ibrahim Omar is asking about the place of leptospirosis in your diagnosis. Why you didn't consider leptospirosis?
No.
You didn't consider at all.
Leptospirosis is called leptospira ectohemorrhagica. So he
Yes.
should be jaundiced and he should have a bleeding problem as
Bleeding
well.
bleeding problems.
Bleeding, ectohemorrhagica, yes.
Bleeding problem. And it's acute kidney injury.
And jaundice, of course.
Thank you, Suez Canal team, for this very interesting cases and this very long, interesting journey. Nice, very nice cases, well presented. And congratulations for all the young children, young generations, our young generations in nephrology. Congratulations for you. Will have a very brilliant future. And congratulations for you, Professor Hamdi, for with your colleagues, young colleagues. Dr. Daulat, Professor Daulat, can we close?
Yes, thank you very much. And
Thank you.
I am quite impressed with Nada and Diana. They are both, I think, joining the deceased donor program, and they are very, very eminent writers. If they are the same, Diana and what's the other one?
They are the same.
Right?
They are the same, yes.
Yes, Professor, we are the same, Diana and Nada.
Yes, yes, I can guess. Very nice.
They are excellent.
They are really excellent, very eminent.
Really very eminent. Yes, they look very eminent and excellent in their presentations.
With their answers and their reviews and the way they write and the references. Very, very good.
عايز اقول كلمه بس ان الدكتوره ندى والدكتوره ديانا دول تلامذه الدكتور عاصم الشريف استاذنا كلنا واللي معلمنا كل حاجه في الاسماعيليه، بس هو طبعا عشان تعبان شويه ما قدرش يشارك.
لا طبعا ده اكيد طبعا واضح يعني.
بالشفاء ان شاء الله.
ان شاء الله. We can give us a hope in the future by listening and seeing their presentations of this young generations. And thank you, Professor Hamdi. You can close this session, please.
Thank you very much. Thank you for everyone. Thank you.
Thank you all, and thank you, professors, for thank you all, professors, for your share, and thank you for all attendees.
Professor Professor Koshawi and Diana and yeah.
Thank you. Thank you,
And
Professor
Nada.
Hamdi. Thank you, Professor Dawlat, for leading this session. Thank you for all Suez Canal team, Professor Muhammad
Thank you very
Koshawi,
much. Yes.
Dr. Diana, and Dr. Nada for their presentations. And thank you for all professors who attended their sessions. Thank you for their share, and thank you for the very nice, beautiful discussion, and for all attendees who shared this. Excuse me to close and announce for the coming session will be by Professor Kuli Palesti from Spain, speaking about brain death. Diagnosis of brain death will be next Wednesday, inshallah. Thank you. تصبحوا على خير. والسلام عليكم ورحمة الله وبركاته.